I think we know quite a lot about religion as a predictor of mortality in adult populations from many surveys and prospective longitudinal studies that have been conducted. So slide is just a very quick bullet points of some of the things that we know. There is a significant protective effect of religious attendance, in other words, religious participation and involvement at the social level, on adult mortality from all causes. And in surveys where there are measures of attendance that show protective effects, there are sometimes also measures of private religiousness, like the importance of religion or intrinsic religiosity. And those items tend not to show protective effects. In fact, sometimes they show the opposite for complicated reasons. So there is a big difference between the subjective experience of religiosity and the social participation part of it, which is where the protective effects are. There's plenty of research on what some of the mediating mechanisms are, and religious attendance operates in many studies through these very plausible pathways. So people who attend religious services more often are less likely to smoke cigarettes, eat a healthy diet, they have only moderate alcohol use, they get preventive screenings, and all of those positive health behaviors associated with religious attendance also have effects on health, positive effects on health. And of course, the social support and networks that people are attached to when they belong to a religious community are very protective on their own, and the linking of one's type of social network to other types of social networks enhances the protective effect. And then the social capital of belonging to religious institutions, particularly in disadvantaged communities, can be a very significant one, allowing the sort of social power of that institution to redound to the individual level. And so we conclude that religion is should be thought of as one of the social determinants of health. Religion is one of the circumstances into which people are born or not, and so therefore it has a life course influence that is a characteristic of the other kinds of social determinants, and those effects can accumulate over the life course. So it's a very important I guess, characteristic of the lives that people live, and its presence or absence certainly has health effects. So just to give you one example of a study, this is our study from +1 in 2017 using data from the Health and Retirement Study, which is a large representative sample ongoing of older people in the United States. And I promise I will only show one slide that looks like this, and this isn't even the whole table. I hate when people show slides like this, but just to illustrate a couple things about the study. We used, this was a 10-year follow-up of data from about 12,000 people. Excuse me, 18, I'm looking at the bottom, I should have said. And we had measures of religious attendance, of how important religion was, and of the kind of religious affiliation that people had. And so this just represents models across here with cumulatively adding controls. When religious attendance is in the model by itself, you can see that there's a 57% lower risk of all-cause mortality for people who attend religious services more often. Let me get my pointer up here. Okay, it won't go away now. And when we add age and other social demographic variables, the protective effect actually increases to 59%. And then when we add socioeconomic status controls, it reduces it a little bit. Health status, adjusting for health status at the beginning of the study, again reduces it a bit. When we add smoking and other kinds of health behaviors, you can see that reduces it quite a bit because of, as I said, the better health behaviors of people who attend religious services more often. And social networks also still a very significant protective effect for frequent attendance. But there is a dose-response relationship in each of these models, and even occasional attendance still has a significantly protective effect, except in the health behavior model. And so attendance is a very strongly protective characteristic of older people in this representative sample from the United States. And there is a measure, as I said, about how important religion is, and you can see that these are increased hazards of mortality from all causes, not by a lot, rather small, but nevertheless increased, very likely because of the older age of this sample and the seeking of religious support and consolation by people who have poor health. That's not testable, but that's my interpretation of the meaning of that increased hazard. And so then religious affiliation is a complicated story. I don't think it's germane to the topic today. So I just wanted to give you what one example of this looks like with very strong protective effects in a really well-designed study that's been going on since 1992. They only asked questions about religion in 2004 for the first time, and so that was when our study started. And I'm going to come back to these data in a minute. But let me just say, so I think we know a lot about the individual level based on surveys and prospective health outcomes, especially all-cause mortality. But there is another level and another way of thinking about religion, not just as a characteristic of individuals, but also as a characteristic of societies. And there are a much smaller number, but very interesting studies about religion and as a social characteristic. One early one came from a book by Victor Fuchs, the health economist, who compared death rates in two adjoining states in the United States, in Utah and Nevada. Utah is well known for having a very predominantly Mormon population, a highly religious sectarian group with extremely good health behaviors, and compared with Nevada, which has very much higher death rates in all categories. And he attributed the main difference to the lifestyles of people in Utah that were in many ways conditioned by their Mormon religious beliefs. Some other studies have shown that the contextual or the institutional level effects of religious schools show some protective effects for marijuana use, regardless of how individually religious a student is. Simply being in a school that has a more religious ethic to it reduces marijuana use. That was from some national data, also from the University of Michigan. And some other studies have looked at religious pluralism. More religiously diverse societies show the more positive effects of individual religious participation. And religious attendance and self-rated health seem to be greatest for the oldest age groups. That association is strongest there. So there are these larger contextual effects that may condition or even have independent effects that are aside from the individual religiosity of a person. So that's the issue that I want to raise in the talk today, is what is the impact of context? And by that, more specifically, I mean the context of secularization. So the debate about the secularization of society has been going on for a long time, especially in Western Europe. And until fairly recently, there were many people who maintained that the United States was an exception to the secularization theory, in that religiosity, religious participation, and attendance remained somewhat higher in the United States than they were in Western Europe. And so some researchers called this an American exceptionalism, sometimes even saying that this is the fatal anomaly that disproves the entire theory of secularization, because the United States is not going down the path of Western European societies. And other people were simply saying, well, it's just taking longer in the United States. I have a photograph of here, of Peter Berger's book, Religious America, Secular Europe, that was making the argument that the United States is exceptional. But I think we know now that that isn't the case. This article that was in the American Journal of Sociology by David Bose and Mark Chaves of Duke University looked at a very long series of general social survey data. And this graph shows the cohort-specific levels of what they called strong religious affiliation, not just having a religious affiliation, but identifying strongly with it. And as you can see here, so in the early years of the survey, back in 1973, these are survey years here along the x-axis and percentages along the y-axis. The 1915 and earlier birth cohorts were over 60%, nearly up to 70%, saying that they were a strong Roman Catholic or strong Methodist. And then there are lower levels for the 1915 to 24 birth cohorts and lower for 1925 to 34. You can see these lines barely even cross each other. So there's a real generational shift in the declining proportion of people who say that they are strongly affiliated with a religious tradition. And of course, the least likely to be affiliated are those born from 1985 to 94, with just in the low 30%. So, I mean, really, like, this is a decline by half from people born in the early part of the 20th century to people born in the late part of the 20th century. This is the data for religious affiliation. It looks quite similar for, oh, did I go too fast? Yeah, I'm sorry. It looks quite similar for regular attendance, attending monthly or more often. Here are the 1915 and earlier birth cohorts up here with 60% or more saying that they attend at least monthly. And here are our millennials, and everybody arranged in between. So this is a real shift from one cohort or one generation to another in the United States, showing a decline in religiosity for affiliation, for attendance, and then for the third one, the third question that the General Social Survey had was, I know that God exists. And here we have over 70% from those early birth cohorts, and then declining down to the 40% or so for the more recent birth cohorts. So overall, I think with the publication of this particular article, and also I would like to mention the Pew Research Center has just recently embarked, beginning in 2017 or so, on a very interesting program of research on religion and demography, and age and the generational patterns that we see here are very much a part of the research that they have been doing at the cross-sectional level. These compiled cross-sectional surveys from the General Social Survey, though, are really quite definitive in showing us that secularization is perhaps lagging in the United States by comparison with Western Europe, but that the pattern is very similar. So, why are these trends in secularization important for health research? I want to try to bring these two kind of recent research areas together. So, one thing is that many of the studies of religion and health, especially the religion and mortality studies, have been conducted with older populations. Initially, that they were conducted with older populations. And so it's possible that there is some bias there. If we are only studying the older populations, just to go back here to a minute, we're only studying these people who have rather high levels of religious attendance and participation. And also this group has is more likely to have poor health. So there could be biases that are changing our results. Now, not all studies have been conducted with older people. There are studies of adults too. So, but I still think that many of the early studies, especially, have been with older populations, and that's also the theme of this conference. So it's well known that in research on any form of social participation, especially religion, and older populations, there's always the threat of causation, reverse causation, because people who are in poor health, in declining health, may be less able to participate in different kinds of social activities, including religion. And so, and they also may tend to have enhanced subjective measures of religious involvement due to the suffering or the other kinds of health problems that people are seeking comfort for. And then finally, there is the issue of selection. If we show, as many studies have shown, that people with higher levels of religious attendance are less likely to die over long periods of time, that means that people who survive to old age are among the more religious members of those cohorts, because less religious members of those cohorts have already deceased. And so these seeming secularizing trends might possibly be kind of covering up or hiding a tendency for people who are in these younger cohorts to have not experienced that level of selection that those in the oldest cohorts have. So there's a lot of tricky things going on. So what I'd like to do and present some research to you today is to ask if the findings from the General Social Survey are represented in the data from the Health and Retirement Study. So do we see the same age-based secularizing trends in the Health and Retirement Study that we've seen in other national data from the United States? And then I wanted to ask, does this individual level association between religious participation and mortality that we already showed in the example that I showed you from the +1 study, does it vary by cohort? Younger cohorts are experiencing a more secular context with more of their peers not being involved with religion. And so I think that's an important question to ask, whether the context is having an effect on this individual level association. So the data come from, as I said, the Health and Retirement Study. This is a study that interviews people every other year. It is publicly available data that you can go to their website and download if you're interested. It began in 1992. It is nationally representative of non-institutionalized adults, but it does not, it will follow people who began in the study if they end up in a nursing home, but it doesn't sample people in nursing homes. They do the interviews in home or sometimes by phone. They oversample African American and Hispanic households, and they use a very, very clever technique for gathering economic data. The purpose of the Health and Retirement Study was to begin assessing the health and economic status of people who are still in their working years. So that's why they start with people who are age 51 and then follow them up through retirement. Somebody could put themselves on mute. I can hear.
De paseíto, ¿eh?
I guess I'll just carry on. The response rates are really good. This is an excellent study that has really pioneered some new measures for getting people to estimate their economic wealth and income, and it's really very clever. So we started the data from 1992 to 2004 asked about religious affiliation, but they didn't ask the other questions about the importance of religion and attendance at services. So this study begins in 2004 because that's when these primary predictor variables were first available. And so the sample is 20,192 people, and this is including respondents and their spouses. This is an important feature of the study that I'm talking to you about now. If a person in the study who is older than 51 is married, they recruit the spouse, and many spouses are younger than 51. So there actually are people in the study who are younger than 51. And so, so that's how I'm able to take a look at some of these younger cohorts. This is just a little schematic showing the way they accumulated different generations into the health and retirement study. And so you can, the main point is that although they started with the original 1931 birth cohort, then added much older people, by the 2016 wave of data, they had included both the early, mid, and late baby boomers. So all baby boomers in the United States, that large cohort that was born after World War II, are included by 2016 in the study. And here are some frequencies. I don't think I need to walk through these very carefully, but in the age range, as I was mentioning, because of we have the younger spouses involved in this sample that I'm talking about, there are people as young as 24, but there are people in their 30s and 40s, very few in their 20s, but some in their 30s and 40s. And it is a generally relatively healthy and relatively well-off population. You can see that 63% are married, and these proportions of religious affiliation are pretty similar to national levels, as they should be, since this is a nationally representative sample. And their education, income, and assets are, as I said, this is a relatively well-off sample. They are also relatively healthy, and I'm just giving you some of this background. These don't play an important role in the analysis I'm going to show you, but if you're interested in some of the characteristics of the sample, this is what it looks like when you include the younger spouses. So what I'd like to do is show you some analysis that we did of the cohort-specific levels of religious attendance, importance of religion, and I'm going to go back to them, and saying that people had good friends in their congregation. So what we did was look at the survey years. Let me collapse this so I can see my own graph better. So this is the before 1915 birth cohort. And these are their responses, the percent who were attending services weekly or more often in each of the survey years. So the survey years are progressive here from 2004 to 2016. The before 1915 birth cohort is really small. They're back in 2004 when we're starting our study, there were only 563 people, and that had gone down to only 9 people by 2016. But what you can see here is that, you know, for the 1915 birth cohort, many of whom are experiencing poor health in old age, are between 30 and 40% of them up until this last year are saying that they attend services weekly or more often. Then as we move to the younger birth cohorts, the 1915 to 24 birth cohort, and so all of these who were pre-baby boomer cohorts, these 3 born before the end of World War II, are all showing very high levels of weekly attendance in all of the survey years. Between 40 and 50% are saying that they attend religious services weekly. Then we hit, you can see we have a kind of a level up here in the 40s, and then we hit the baby boomer cohorts, 1945 to 1964, down in the low 30s, a noticeable drop off from these previous pre-baby boomer cohorts, and then some more variation among these younger groups, as I said, who are the spouses, but there is clearly a downward trend in the proportion of people who are reporting weekly religious attendance by cohort. We're not looking from one survey year to another here. We're looking to compare one cohort to another. So that's what it looks like for religious attendance. As for the question about how important is religion to you, again, there is a decline. You can see that the baby boomer cohorts are all up here around 70% saying religion is important to them. And our baby boomer cohorts are down here in the 60%, and the post baby boomer cohorts are lower than that. So maybe not as sharp a downward trend by cohort, but nevertheless still a slope you can see. And then finally, the proportion, this one question was only asked in 2006 to 2012, but health and retirement study participants were asked, do you have good friends in your place of worship? And again, you can see that we've got the pre-baby boomer cohorts up here above 70%, and then our baby boomer cohorts, and after that, are in the 60%. So even, even though baby boomers are still representing a fairly high level of religious participation, they are clearly not as high as the pre-baby boomer cohorts. And just to mention health, are there differences in health by age in the health and retirement study? Yes, of course there are. So these graphs are reporting by age group in 2004. The percent that are reporting no major conditions, no sensory impairment, no symptoms, no minor conditions, ADLs, and excellent health. So you can see that the proportion reporting no health problems is pretty high among those who are under age 50 and much lower among those age 90 and older. So the percent reporting no pain for some reason is level across all groups, but the others are all much less likely to be reporting no health problems for those who are 75 to 89 and those who are 90. So we have older cohorts with poorer health and simultaneously higher levels of religious involvement, kind of the opposite of what that reverse causation argument usually tells us. And so here we come to the final question about does the apparently more secular context of the baby boomers and following cohorts, does that have any kind of impact on the individual's association with their religiosity or their attendance at religious services and mortality? These are the hazard ratios. So I showed you hazard ratios for the from the +1 study that we had done earlier. But here we're breaking the groups down into the age groups of 50 to 64, 65 to 74, 75 to 89, and then 90-year-olds and older. And the same protective effect is there for people who attend frequently, those who attend regularly, and those who attend occasionally. And so for the 50 to 64-year-olds, there are the strongest effects. All three of these categories of religious attendance have confidence intervals that are below 1.0, showing that they are all statistically significant. And there is a certain dose-response relationship between frequency of attendance and protectiveness, and with more frequent attenders having the biggest protective effects. That is similar for the 65 to 74-year-olds, although the protective effects are a little bit less. Just comparing these bars one to another, they're a little bit closer to 1 and therefore slightly less protective, but still significant in all cases. When we get to the 75 to 89-year-olds, the group that attends occasionally no longer shows a significant protective effect, but the other two do. And then with the 90-year-olds, all the confidence intervals intersect or overlap 1.0, but nevertheless, visually, there is still the same kind of dose-response relationship with this group that is is definitely smaller and definitely in poorer health, and has also experienced most of the selection effects that we talked about earlier. So let me just sum up some of the limitations and the takeaway messages that I'd like to give you, and then we'll have time to talk. So one limitation is that all of the health and retirement study data that's public use that I used is self-reported health information. So there are physical measurements and some biomarkers for certain subsets of HRS respondents, but I'm not using those data, and they're more restricted. So basically we only have self-reported data, which certainly has its own limitations. There are no medical records included either. There are only 3 measures of religious involvement in 2004. Like I said, they added that, having good friends in the congregation for several years, but have taken that back out again. And so there are many dimensions of religion and spirituality. And for example, there is no question about how spiritual a person are you, or how important is your spirituality to you. I think that question possibly is more relevant to younger cohorts than it might be to older cohorts who see religion and spirituality as essentially the same thing. Younger cohorts may make a differentiation between that and give different answers to those questions. But there are many other dimensions of religiousness that could be measured and were not in the health and retirement study, which, as I said, is a very large study that has many aims besides studying religion. I wouldn't say that that's a central aim of the HRS at all, but it's fortunate that they have included these variables for researchers such as myself. So some takeaways. The health and retirement study is really great. The ability to study at least 3 dimensions of religiousness in an older sample, and the very excellent measures of health, the extensive measures of health, even though self-reported, they are very detailed. It is really valuable. And then the fact that you can access the spousal data so that you actually have some younger cohorts represented is really a great privilege to be able to study such an excellent data set. So religious involvement in terms of attendance, in terms of having friends in the congregation, and in terms of how important religion is, it was lower for each successively younger cohort. And that certainly mirrors the trends in the general social survey that I presented at the beginning of the talk. And I think that there are just so many ramifications of this. So one thing is that it means that the earliest birth cohorts, who are showing the highest levels of religiousness in old age, are also the ones who were raised in the most religious environment. They were born into families that were very religiously observant, and they spent their lives with fairly stable, as you could see, most of those curves in the general social survey were pretty flat. They wandered up and down, but they showed a sort of stability within the generation of the level of religious involvement. The big difference is between cohorts, not within them. So for the earliest birth cohorts, that religious context in early life and continuing into old age is a feature of their lives that is different and will be different for younger cohorts. We saw some differentiation between the pre-baby boomer cohorts and the baby boomer cohorts, but still the baby boomer cohorts look more like the pre-baby boomer cohorts than they do like those who follow them. And that would fit very much with the declining levels of religiosity that we see in the general social survey, with the biggest fall off being among the millennials and later. The generation X, Y, millennials, all of those who follow the baby boomers. So just to mention a few issues about the selection. So, as I mentioned, in 2004, that earliest pre-1915 birth cohort had 563 people in it, born between 1897 and 1914. So these were definitely the most likely to say that they had a religious affiliation, and also to say that religion was very important to them. And although they didn't have the highest levels of attendance, likely because of health limitations, still 35% of them were attending religious services at least once a week, which is a lot. So to continue with some of these take-home points, the prevalence of health conditions increases with age. So the problem of reverse selection, in other words, health limitations preventing people from being able to attend religious services, is definitely more of a concern for the older cohorts. And so when we looked at the hazards of mortality by the specific cohorts, it seemed that there was a somewhat of a pattern of those hazard ratios creeping up as among the oldest ones. Let me just go back to that slide. You can see that this is the line of no effect through the center here. So we can see that there is a more protective effect for the younger people, and that it seems to be slightly diminishing and decreasing as we go into the older cohorts. And so that's what I want to say. There's a couple of explanations for that. So one of the reasons that that might be occurring is because there is selection by mortality. The oldest cohorts, as I was saying earlier, if the process of a health protection effect of religious attendance is present throughout adult life, that means that the people surviving to old age are likely to come from the more attending, the people with higher religious participation compared to those with less. By the time people reach their 90s, this selection would have pretty much played itself out, and so you might see a diminishment, although the possibility is the dose response relationship was clearly still there, although the hazard ratios were not significantly different from 1.0. So that's one possibility, selection. But the other is that there's more protective effects in the more secular cohorts. And that is a takeaway finding from some of the context studies that we've seen in the past, which is that in a secular context, people with continuing religious attendance, despite the more secular context, could have a heightened protective effect of their religious affiliation, which they have, which is more unique to them, which is differentiating them from other members of their cohort who are more secular. And then just to conclude, one point that is something I think about a lot, which is that, if this generational and historic shift is continuing, which I see no reason to think it will not, then that means that today's baby boomers, who have all entered the old age period of 65 and older, are entering old age with a relatively larger social network due to their religious attendance and patterns, but that succeeding cohorts will be entering old age without those social ties that come from the social networks and participation of a religious community. And I don't know, people always ask me, well, what are the replacements for that? And I don't know what they are. I don't see any obvious ones for sure, but we can talk about that if you'd like. And so there is something of a parallel with marriage rates in the United States and in Western Europe. So marriage rates are declining, and more people will be entering old age with fewer of the marriage-related social ties, as well as fewer of the religious social ties, leading to an overall decline in social networks in old age. And we certainly know that social isolation is a serious hazard for, we know it better than we ever did before, for health in old age, and that it seems as if more and more people will be carrying that risk with them into old age. So I think, although, as I said, baby boomers look more like the pre-baby boomer cohorts than they do like those succeeding them. I think we don't know what's going to happen yet. Baby boomers have now all entered old age with a relatively large set of religious and family ties. But when those ties are diminishing for the succeeding cohorts, I think I don't know what's going to happen. It doesn't seem like an optimistic scenario to me. Ending on a very negative note. I'd be happy to take questions.
That's great. Thank you, Ellen. I think it's really good to just see how important context is, and remember all those things around, confounding factors and things like that is so important. So we have a first question for you from Arndt. Would you assume that religious attendance is a matter of the building, so the church, the social group, i.e. the community, edification, the effect of the preacher, or spiritual nourishing, as in prayer time? So that's just an easy one to start you off with.
That is a great question. That is a terrific question. I love it. Well, you're right. That's got many parts to it. But I have to say, the first thought that entered my mind was to say, well, is it the building? Given that religious attendance has been severely interrupted in the COVID pandemic, we know what religious participation looks like when there's no building involved, right?
Yeah.
And so I was very privileged to be aware of a group of multi-faith clergy at Emory University that started a Facebook group for multi-faith clergy to help each other on Zoom to figure out how they could take care of their flock. And it was absolutely wonderful to read how much sharing there was among clergy, how much they were coaching each other on Zoom and giving each other tips for having online services, and it was a real support community. So I would say that clergy pivoted quite quickly to holding services online, which of course is hardly perfect. And with technology limitations, especially of older people, that was difficult. But there were heroic attempts of clergy to continue, shall we say, gathering online. And so let me also just bring up singing and music, because that is such an important part of most people's experiences of worship. In all religious traditions, there is music and participation, not only by skilled musicians, but by the congregation and lay people. And as you, I'm sure, are all aware, a choir rehearsal at a Presbyterian church in Washington State was one of the first major outbreaks in the United States, traceable to the 3-hour rehearsal that they had. So I'm a member of my choir. I'm an alto, and our choir director has been holding. It'll be tonight at 7:30 on Thursday nights. Instead of choir rehearsal in the building, we have Zoom. We put ourselves on mute and we sing, and she watches our mouth. I don't know how she knows whether we're actually getting it or not, but she does breathing exercises, and so I know that music directors. I've been also on some webinars. Have also learned how they can do coaching online with musicians and teach them exercises and scales and practice. And then of course there's virtual choirs. So some of you have probably seen some of the really excellent ones. I've participated in some. I don't think I'm an excellent singer at all, but it was really fun and challenging. And so I would say that the building is a lot can go on that is social. but not in person. But nobody likes that. And, the social gathering is really the important thing. So I'm looking forward to, being social again with people that I know that I haven't seen in person in a long time, very soon. So there were other interesting parts of it. I mean, as far as edification goes, I love that. Yes, the services that are online allowed clergy to preach and to teach, and I know that my church particularly had Zoom Sunday school, and the kids were all online with the teachers, and so there. Yes, there can be preaching and there can be teaching and there can, in a way, be music, but the music is pretty pathetic. But hopefully we'll be able to sing again in person, even if we have masks on. So I don't know if I answered all the parts of that wonderful question, but thank you for it.
Great. I think we've got a few more questions here. So Ulrich's asked, are you aware of any comparisons between different groups within the US, such as New England versus the Bible Belt, or white evangelicals versus black evangelicals?
Yes, within the U.S. So I lived all my life in the Mid-Atlantic states, and that would be considered a very secular part of the United States, the Mid-Atlantic and New England states, Northeast. By comparison with the Southeast, and I went to teach at Emory University, which is in Atlanta, I immediately noticed that there were more people at the grocery store in their church clothes on Sunday in Atlanta by far than you would ever see in New Jersey. So there are absolutely differences that are regional, and I think that that's a great question, specifically because I wanted to talk about context. And so I feel like I'm just starting to go down this road of understanding the impact of context on individual associations. It did seem as if the more secular context, at least for, those 50 to 64-year-olds, did not seem to have any impact on the individual effect, but you have fewer people having the individual effect. More people have that potential protective individual effect when they're in the more religious context, such as the Southeast.
Great. Next question is from Tobias, and it's related to Arndt's question. What would you consider constitutes religious community or social activity? Anything exceeding religious activity with oneself, or does it have to be a larger number of peers?
Oh, well, I think there's a scripture phrase that says where one or two are gathered, or two or three are gathered. So yeah, it can be very small groups, but yeah, so even a group of two is a social group. I would absolutely say that a very large group is not necessary, but so I'm a sociologist. Emile Durkheim, the French sociologist, wrote about the power of mass gatherings in elementary forms of the religious life, which I read a sophomore year in high school, and it changed my life. It's a very amazing book. Durkheim tells us that religion comes from society, and it comes from the gathering of people, and the power of mass gatherings is a very profound one. And so all religious traditions have some mass gatherings, some of which may be very few, once in a lifetime, for people who complete the Hajj, for example. But yes. So the mass gatherings are really important, and expose people to the power of a really large group of people doing something in unison, whether it be singing or speaking or praying. And pilgrimages and annual events, I think, carry a great weight for all religious traditions. But there's nothing, but I don't, anyway, but that's just not to take away from when two or three are gathered. That's important too.
Okay, so I think we'll just take the last two questions now. So from Lindsay, Ellen, what can be the role of religious community religious communities, churches in this tendency, do they also have a responsibility in the form of sociological perspective? I don't know if I quite understood that myself. So, Lindsay, if you want to clarify, please do.
Yes, it was my question. So do churches or religious communities have an own responsibility in these tendencies of declining religious attendance? Or what can we do? Or we just have to wait as a religious community? Or can we do something?
I love that question. You guys are asking excellent questions. I give talks and sometimes I can predict what all the questions will be. I didn't predict any of these questions, so I love them. Thank you for that one. I have never actually thought about it quite that way before, but I have to say that I was very inspired yesterday by a 3-hour webinar that I was not a participant in. I just went to it. I didn't have a speaking role. That the National Council of Churches and other faith groups put on. It was called Faiths for Vaccines. And there were religious leaders. This was 3 hours of panels of religious leaders addressing different questions, youth groups, all different speakers from different walks of life, talking about how to have their religious communities be on the front lines of vaccinating people and countering vaccine hesitancy and how to speak to people and how to be role models and how to use their own facilities as places where people can be vaccinated. And it was so inspiring to see this outreach to the community. They weren't just wanting to minister to the members of their churches. They were wanting to minister to the entire communities that they were part of. And as I said, it was multi-faith. It was absolutely incredible. So I think that leadership in movements, for example, right now, this is our social problem, is expanding vaccine, and many people in religious groups are among the most hesitant. So this is where the work needs to be done, for sure. But also leadership in social justice movements in the United States, in Black Lives Matter and other economic social justice movements, does come from people in religious traditions. And I think the more that they can be involved in the forefront of those social movements, the more they can bring an important message of their religious traditions to social justice and to improving the well-being of their community. So that would be my answer. I don't know if that's the right one, but I think that we need to be out in front.
Great. And last question, another interesting one. Is there any evidence to support the notion that older people often serve as volunteers in churches, and whether this is part of preserving physical functionality?
Oh, that's a great question too. So yes, I would say that that the accommodation, I don't know if that's the right word or not exactly, but the willingness of congregations to adapt their physical facilities for older people with disabilities and limitations is a really important aspect of ministering to their entire congregation. So making wheelchair ramps so that admission to the building is accessible, and allowing people to play important roles, as you said, as greeters or ushers or other kinds of leadership roles for older people is a really important way of maintaining their social involvement and participation and health.